Hello?
Oh no, yeah, video on this phone.
Good evening, sir.
Good evening. Good evening. Good evening, Babu. Shall we start? Asmita? I think we'll wait for 1 more minute.
Yes, sir.
1 more minute. Usually wait for 2 minutes. 8:16. Okay, we'll start. Asmita, shall we start?
Yes, sir, you can start.
Okay. So good evening to all of you. As usual, I will start with the short case first. Is my screen visible to you?
Yes, sir. Yes, sir.
Okay. This is a story of a 60-year-old lady. History of acute onset of dysarthria, dysphagia, and inability to move the right side of the body. This is the video of the patient.
Ma, പേര് പറഞ്ഞേ മാ. ഉറക്കെ പറ. ഉറക്കെ പറയാ. മേരി യോഹന്നാൻ. വീട് എവിടാ? തിരുവനന്തപുരം എന്ന് പറഞ്ഞേമ്മാ. ഇവിടെ നോക്കമ്മ. വിരലി നോക്കേ. എടുത്തോട്ട് മുകളില് താഴെ. ശരി. കണ്ണ് മുറുക്കി അടച്ചേമ്മ.
Bilaterally defective, more weak to the right side. Facial is also more on the right. Beat to the left side.
ശരി. ഇനി വാതിറക്ക്. അടച്ചേമ്മ.
The opening is normal.
ആന്ന് പറഞ്ഞേ.
movement.
നാക്കൊന്ന് നീട്ടിക്കേ. നാക്ക് നീട്ടി.
Unable to move.
നാക്ക് ഇടത്തോട്ടും വലത്തോട്ടും തള്ളിക്കേ. തള്ളിക്കേ.
More problem moving the tongue towards the right.
നല്ല തള്ളി. ഇനി വലത്തോട്ട് തള്ളു. വലത്തോട്ട് തള്ളിക്കേ. ഈ
Ask
വശത്തോട്ട്
him to move to the right
ആ
side.
തള്ളിക്കേ. ഇനി വലത്തോട്ട് 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 തള്ളമ്മ.
He couldn't.
പൊക്കിക്കേമ്മ നോട്ടെ.
Let's go right hemisphere.
ഇത്
Put
പൊക്കിക്കേ.
0 to 1 power. Left side
ഈ കൈ
8
കൊണ്ടിട്ട്
normal. Relatively normal.
വിരലേ തൊട്ട് മൂക്കി തൊടമ്മ.
There is no incorporation of the left upper limb.
ഈ കാല് മടക്കിക്കേ.
It could move the left lower limb, but not the right side. Our plantar was upgoing bilateral.
കാല് വലിക്കല്ലേ. അത്രയും വേണ്ട, പകുതി പാതി.
Logic was absent. So I did not do the gag reflex. I should not have done that. So on examination, patient was on right tube, spastic speech, ocular movements normal, bilateral facial weakness more on the right side, no palatal movement, tongue movements are restricted bilaterally, more towards right side, jaw jack is absent. And motor system, which is right hemiplegia, plantars were upgoing bilateral. So where is your localization?
Could be above pons.
Okay, above pons, which you mean midbrain or bihemispherical lesion?
It could be a midbrain pons junction, or could be a bihemispheric lesion, or could be an old right side lesion with a new left opercular syndrome.
Okay, this situation is most common in that situation. Yeah. Now, maybe wherever it is, it may be old left hemiplegia, mainly cortical bulbar, which remain asymptomatic for long. Now, if you get a fresh lesion on the left side, it will unmask an acute cerebral palsy. That's the thing you have to keep in mind. The problem, she has no wrist jaw jack.
Sir, why can't this be bilateral corticobulbar tracts from midbrain to pons level? Which,
Because bilateral cortical bulbar is affected, but here jaw jack is absent.
yeah, progeroid is absent. So that cannot be explained.
Yeah.
And the bilateral orbicularis oculi also weak.
But the ocular was weak. Yeah, correct. More on weak on the right
It's because
side.
of bilateral UMN, and the jaw jack may not be always present.
Correct. It could be a bilateral human element. We do not know as far as face is concerned.
What about Bell's phenomenon?
Correct. So the question is it a bilateral hemispherical infarct, brainstem? So if it is brainstem, where is it in the brainstem? Is it in the medulla? If it is a bulbar, if it is pons, or is the midbrain? Okay. So the first question is the bulbar palsy element or human? You are 1 point suggesting that it's human because it's got something such as spastic speech. 1 point favoring element because she has got absent jaw jack. So what other tests would you like to do? As Joyce said correctly, you have to do the Bell's phenomenon. So let us see the Bell's phenomenon in this patient.
തുറന്ന് പിടിച്ചോണേ. ഐസ് വരണേ. ഇനി കണ്ണ് മുറുക്കി അടയ്ക്കും.
Ask you to close the eyes.
കണ്ണ് തുറന്നേ.
Keeping it eyes open.
ഇനി കണ്ണ് മുറുക്കി അടയ്ക്കമ്മ. അടച്ചേ 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 അടച്ചേ. മുറുക്ക് 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 മുറുക്ക്.
There is no upholding of the eyes. So that tells you Bell's phenomenon is absent. So where is the lesion now?
More likely element, but can Bell's phenomenon be absent in some people?
No. Absent Bell's phenomenon tells you the lesion is the bilateral facial palsy is UMN. If it is element, Bell's phenomenon will be brisk UMN. So it indicates that so we had a confusion initially because there is element palsy, bulbar or pseudobulbar. Now this tells you clearly it is a upper motor neuron paralysis. It's a pseudobulbar palsy. So what investigation you want now?
MRI.
MRI, which part of the body?
Cortex.
So as told before, we usually expect a cold infarct on the right hemisphere producing left hemiplegia or bulbar palsy. So pseudobulbar involvement on the left side, or corticobulbar involvement on the left side. Now coming with a left hemispheric lesion producing a bilateral pseudobulbar, bilateral corticobulbar producing a pseudobulbar palsy. So this is MRI of the brain, normal, no infarct.
What about upper and lower cuts?
Normal. Brain, lower cut mean what? Medulla?
No, the brain itself.
Low,
Towards
low,
your-
normal. Thalamus, etc. is all normal.
So the
Brainstem.
Okay, which part of the brainstem you want?
pondomedullary, yeah, pons.
This is the medulla. Normal. So what else?
So coronal
Midbrain.
cut, sir.
Midbrain.
Pons, sir.
Yeah, pons. Okay. So pons and midbrain, you see the bilateral cortical bulbar involvement there. Peripheral tract involvement on the anterior part, you can see that. So it's more on the left side. Here, causing the right hemisphere in this patient. So I brought this because only to show that sometimes difficult in acute phase, Georgic may not be elicited, even gag reflex also may not be elicited sometimes in acute UMN. So in such a situation, always go for other evidences of UMN. One such thing is the Bell's phenomenon, because we hardly do look for Bell's phenomenon in such cases. So this is one useful bedside to differentiate whether it's LMN or UMN.
This patient is bilateral pontine stroke, which is acute.
Bilateral, it looks like an acute stroke, but predominantly affection was on the right side.
Left side.
Left side was in the right hemisphere, correct. Okay, it has also got the basal artery is also not visible clear. It is stopping short here. Okay, then I will go to another case. This actually
I
Joy.
have one doubt, sir.
Yeah, please. We always ask.
So the absent Georgiac is because of acute UMN or due to bilateral elements, sir?
No. If you can absent Georgiac normally also may not be elicitably normal, even in normal individuals. If you get a brisk Georgiac, it is likely to be abnormal, not even normally elicited brisk Georgiac. But you expect an acute UMN paralysis, you expect bilateral cerebral palsy, you expect a brisk Georgiac. But what I'm trying to, sometimes it may not be elicited. I do not know why the reason is. Probably it may take some time for the brisk Georgiac to appear, just like any brisk reflexes. So also, gag reflex always need not be positive may not be brisk in acute UMN lesion. May take some time for the reflex to appear. In such a situation, look for other evidences of a cerebral palsy.
But in this case, the element pons is there, no? So then jaw reflex can be absent.
No, but that is above the facial facial nucleus. That is in the upper part of the pons, not the lower pons.
Sir, suppose there is a lesion on both sides, like a cortical lesion, acute left hemispheric lesion. How to differentiate whether it's a pontine lesion like this or a bilateral suitable palsy due to bilateral cortical lesion?
No, you cannot differentiate. Very difficult to differentiate. If you find some ocular movement abnormality like a gaze palsy or INO suggesting a posterior pontine lesion, you can't differentiate. Here also look, it's only the femoral tract alone is affected. The posterior part of the tegmental of the pons is not affected. So you won't get INO or those things will not be there in this patient. It will be very difficult to differentiate a bilateral hemispherical versus an anterior part of the pontine involvement like this. So in fact, I initially thought it's a bihemispherical lesion. Old left humor, recent right hemispherical.
So Georgiac is not facial, it's trigeminal. Which is
Trigeminal, but correct, but still it indicates that the lesion is above fifth nerve, above the midpons. So when you to differentiate bilateral element versus bilateral human, these are the 3 points. One is the preservation of the emotional fibers in the case of bilateral human, brisk Georgiac or brisk facial reflexes. Third is the third point is the Bell's phenomenon, which is absent in human, present in bilateral element.
Sir, why in this case it is absent, sir?
That's difficult to explain, probably because of the acute nature of the lesion.
Okay.
Sir, how to differentiate this from anterior opercular syndrome?
No, in anterior opercular syndrome, actually, it is not the cerebral palsy. You won't get such a spastic speech in acute in opercular syndrome. In opercular syndrome, is different from a cerebral palsy. In cerebral palsy, you get emotional incontinence. You will not get this. You will not get in. Opercular syndrome. You will not get spastic speech in opercular syndrome. You get only flaccid speech in the opercular syndrome, and you get a classical voluntary automatic dissociation. The patient may not be able to voluntarily swallow, but could put fluid in the mouth. Sometimes they may swallow in opercular syndrome. So sometimes difficult to differentiate, and they won't have a brisk charge in opercular syndrome. So you expect a brisk charge.
Sir, George circuit normally may be absent.
Yeah, normally be absent. That's a problem.
What if it's a bilateral opercular syndrome? Do you get a brisk jaw jerk?
No, you won't get brisk charge. Because actually it is something like the lesion is confined to the cortical representation of the bulbar part. It is not, that area is not sustaining not mediating the tone. Or if the fiber tract below is affected, so for example, pyramidal tract itself is affected, which contains the cortically originated extrapyramidal fibers responsible for the maintaining the spasticity or tone. So that will be affected only if the bilateral pyramidal tract per se is affected, not in the cortical area. For example, if you get a cortical hand-knob area affected, or cortex alone area 4 alone is affected, you won't get spasticity. Spasticity in cortical will occur only if the area 4S or 6S is affected. The areas which were responsible for maintaining the tone. Similarly, pure medullary pyramidal lesion, if you cut the medulla of the pyramid of the medulla, again you won't get spasticity. Tone will be hypertonic.
Why, sir? Medulla effect?
Because that area contains only the corticospinal fibers. If the little more dorsal affection can produce, the extrapyramidal fibers also is affected.
Which part of the medulla?
The simple thing is that in spasticity in emphysema is not due to the corticospinal fiber affection. It is due to the affection of the associated cortically originated extrapyramidal fibers, which inhibit the brainstem centers mediating the tone. Similarly, the reticulospinal and vesiculospinal tracts.
The medulla, which part of the medulla is cut? There will be no spasticity.
There are two parts there in medulla. One is the two main tracts. One is reticulospinal tract. There is lateral reticulospinal tract, which inhibit the stretch reflexes. Another is the vestibulospinal tract, which is anterior, which facilitate it. Okay, so this reticulospinal tract is normally inhibited by the cortex, which accompany the pyramidal fibers. So this is actually driven by the cortex. So when that fibers are affected, these reflexes are disinhibited. That means the tone becomes spastic. The inhibitory fibers are taken off. So tone becomes the gamma efferent activity, and the gamma rigidity and alpha rigidity become unmasked, which normally gets suppressed by the inhibitory input from the inhibitory reticulospinal tract in the medulla, which is driven by the cortex. Anyway, that is pure physiology. Okay, so you may not get that point is that in opercular syndrome is not equivalent to a bilateral cortical bulbar involvement equivalent to bilateral cortical bulbar involvement, producing weakness of the facial muscles, pharyngeal etc. The other compounds cerebral palsy like brisk jerk, spastic speech, emotional incontinence will not be there in opercular syndrome. Shall I go to the next case?
Okay, sir. Thank you, sir.
Okay. First is
sir,
the question.
Sir, one more question. Suppose there is a lesion in the pons and the opposite cortical, the cortex also. You get the same clinical figure.
Same picture. Same picture.
Yes.
Same picture. Okay, this case is actually Joy's case. Before that, I will pose one question to you. It's a multiple choice question. A 30-year-old man gave the following complaints. I get dizzy whenever I hear loud noise, like honking of a vehicle. I had fallen 2 times when the sound was very loud. Sometimes I can hear my chewing, belching, borborygmy, and even my footsteps in my left ear. What do you think about this dizziness?
Superior canal
Superior canal dissonance.
Pardon?
Superior canal dissonance. Superior canal dissonance.
Okay, you're perfectly right. Okay, you anyway give the answer. So the question has no relevance now. So they hear this story in this patient. What he is telling is that when he walks, he hears his steps in the left ear. No deafness or tinnitus or vertigo. This complaint has been there for 2 months. This is the story of the patient.
നടക്കുന്ന സമയത്ത് നമ്മൾ സ്റ്റെപ്പ് വെക്കുമ്പോൾ നമ്മൾ അടിക്കുന്ന പോലെ എഫക്ട് ഉണ്ടാവും ലെഫ്റ്റ് സൈഡിൽ മാത്രം അത് ഈ കണ്ണിനും അതുമാതിരി ഇങ്ങനെ ഒരു ഇതേ അതായത്.
Did you hear the story? When he walks, he hears tuck noise on the left ear, not on the right side. So what is this symptom called as? Any particular name for this particular symptom?
Autophony, sir.
Autophony. It's called autophony. So what clinical test will you do to diagnose this condition at the bedside?
Tragus, pressure on the tragus sign, sir.
Okay, that is one Henneberg's sign. That is not specific for this autophony, but for only the perilymphatic fistula. Okay, it's good. Any other test?
Tuning fork, vibration.
Where will you put the tuning fork?
In the mastoid region.
And normally also will kill the vibration also. The 3 things you can do. One is Tullio phenomenon. If you get put a sound here on the ear, the patient may get misdiagnosed and vertigo. Third and more important is the tuning fork test, where you put the tuning fork on the limb or the sternum. If you put tuning fork on the left patella, he will hear the tuning fork on the left ear. So this was done. This Joy has done this patient. So he has
ശബ്ദം ചെവിയിൽ കേൾക്കുന്നതാണ് ഉദ്ദേശിച്ചത്. ചെവിയിലാ കേൾക്കുന്നത്. ഇപ്പോൾ ശബ്ദം കേൾക്കുന്നുണ്ടോ?
he was hearing on the left ear.
ശബ്ദം.
Now, these symptoms are typical of what is called third window abnormalities of the labyrinth. So I think we may not be very well versed with this particular condition. So I will spend 2 minutes on this, the pathophysiology of this, why this vertigo, why these people have conductive type of deafness. Bone conduction is better than their conduction. So I'll tell you why this is occurring in these patients. These categories are called third window abnormalities of the labyrinth. And superior cervical dehiscence is one among them. Now, this is called, these are all coming under this particular category of perilabyrinthine fistula. That is destructive middle ear processes that erode the attenuated optic capsule can produce inadvertent communication with the inner ear, known as the perilymphatic fistula. When this involves the semicircular canals, the vestibule and the scala vestibulae side of the cochlea, third window mechanism can result. Forget about this statement. I will explain to you a little more later in detail. Normally, the physiological windows between the middle and the inner ear are the oval window, which transmits vibration from the auditory ossicles, that is here through the stapes. I'll show the diagram. And second is the round window of the cochlea. These are the 2 windows from the 30 for the labyrinth. When the third window appears, there's a problem arises. So I'll tell you what is this third window. The pressure difference between the cochlear perilymphatic spaces activate the head cells and create the perception of the sound. So this is the labyrinth. Now this is the simple diagrammatic representation. You can see this is a external auditory meatus. This is the ingus, malleus, and stapes. This is stapes which is attached to the oval window here. This is the scala vestibulae. With below one is the scala tympani. So when the sound comes, this is energy is transmitted through this oval window, through the perilymph in the scala vestibulae, which goes all around the cochlea, down to the top, through the modulus, and then comes out through the scala tympani here. and it comes out through the round window. This is what is normally happen when the sound impulses reach the middle ear. Now, this transmission of these waves will produce vibration in the basilar membrane, and the receptors here, the hair cells, get stimulated and produce a sound. This is the normal physiology. This is please forget about this thing. Now, this is a diagrammatic representation. You look very carefully. This is the tympanic membrane, the ossicles. This is the oval window. This is a round window. This is the vestibule. Here is a semicircular canal situated. This is a vestibular aqueduct. From the vestibule, these are part of the cochlea. Here, it is like a spiral. It is made into a long one. It's a diagrammatic representation. So when the sound here reaches the oval window, it produces actually pressure waves here. That goes transmitted to the scala vestibuli and through the modulus, then comes out through the scala tympani, and this membrane will bulges out because of the pressure transmission. Okay. So the vibrations of the tympanic membrane are transmitted inward through the auditory ossicles here and the oval window. Energy is conducted through the incompressible perileum. There is a perileum. The dark, the violet is the endoleum. Produce equal outward motion of the round window. This is usually what is happening. The difference in the vibration between the oval and the round windows generate a pressure gradient across the basilar membrane, activating the hair cells and creating the perception of the sound. This basilar membrane is here only, in the scalp, where the endoleum is situated, where the hair cells are situated. This is the normal physiology. What happens in third window abnormality is that apart from these two windows, there is an extra window. So what will happen? This energy or pressure will be transmitted away rather than reaching the scalar tympani. So this is one window, that is a superior cervical sense. There is a defect here. So the pressure will not reach the scalar tympani, will go transmitted here. Similarly, the other is the endolymphatic, the EVE, otherwise called enlarged vestibular aqueduct syndrome, is again transmit the pressure. Third is the cochlear dehiscence. These are the conditions coming under these third window abnormalities. So what happens is that there is a third window abnormality, like for example, superior cervical dehiscence. The decreased air conditioned third window anatomy. This is due to the shunting across the third windows. There is decreased energy transmission from the oval window to the round window. So part of the energy is dissipated here, so it will not reach the round window. So decrease the pressure gradient across the basilar membrane yields reduced sound perception. That is decreased sound perception. So what causes decreased sound increase? What causes the vertigo is because in the presence of the third window, the incoming acoustic energy from the oval window is shunted away, decreasing transmission to the round window. And this reduces sound perception because there is acoustic energy. The pressure gradient between the oval window and the dehiscence causes flow of endoleum in the superior canal ampulla, causing vertigo and nystagmus corresponding to either excitation or inhibition of the superior canal. So I'm going to the picture once again. So when there is transmission here, this will be transmitted to the superior canal. That will be either stimulated depending upon where the fluid is reaching. So we get vertigo and nystagmus. That is stimulated on one side without any corresponding inhibition of the opposite side. So you get a vertigo. Mismatch between one superior canal and the other posterior canal. So you get a mismatch and get a vertigo. That is where vertigo occurring is superior canal dehiscence. So the three cardinal symptoms are: one, sound-induced vertigo called Tilio phenomenon. The one, pressure-induced vertigo, as you already told, that's Henneberg's sign. You put a pressure on the tragus, you get vertigo. And the bone conduction hyperacusis. The bony hyperacusis manifests as symptoms of autophony. Hearing one's own voice as loud and distorted. They can have pulsatile tinnitus, and audible eyeball movements will be audible to them. Footsteps, chewing, even bowel movements will be disturbing for them because they are hearing on that affected ear. And they can have chronic disequilibrium. Now, to understand the pathogenesis of this abnormality, why the bone medial type of deafness occurs. Further, one must know the physiology of the normal bone conduction. Why in putting 24 here, you are hearing it. This is again the same diagram. Here, when you put a 24 on the mastoid, this vibration directly come here, not through the ossicles, transmitted throughout the aortic capsule. This transmission results in differential outward motion of the oval and round window. This is reaching here, and this will come out like that from the oval window and round window due to unequal impedance of these two structures. The resulting pressure difference across the basilar membrane enables sound perception. That is why with a 24 for the mastoid or on the skull, you get the sound perception. What happens here is that in case of third window abnormalities, due to the shunting across the third windows, the decreased motion of the oval window on the scala vestibulis on this side, there will be, because of the shunting away, the transmission here will not reach the oval window. There will be disparity between the two, and you get conductive deafness. However, the motion of the round window on the scala tympani side is unchanged. This is unchanged. This is decreased. This phenomenon artificially elevates the pressure difference between the base across the basal membrane, resulting in increased sound perception when you get a conductive, you mean a mastoid stimulation, or when you check for your conductive deafness. So this transmitted will be exaggerated because the difference is more, because this is shunted away. So you get an increased bone conduction. This is the, okay. I think I will skip this. One important clue is that audiometry, it shows increased bone and increased bone conduction, decreased air conduction, just like you find in conductive deafness. And this is mainly for the low frequency hearing loss. Imagine if you were to take a thin cut, you may find the resistance of the sibilation second. I think I'll skip all these things. I'll show one. So, what investigation do we do in our patient?
CT of the inner ear, sir.
Okay. So before CT, the MRI was done. We showed an interesting finding. Showed a patulous eustachian tube here. Is this eustachian tube on the right side here? This on the left side. It's not at all open. It is wide open. So patulous eustachian tube is less common and results from eustachian tube remains permanently open. Patients patulous and eustachian tube often combine a feeling of pressure in their ear and abnormal hearing of their own voice or recording, just like our third window abnormalities. So I think I'll skip these things. In patulous eustachian tube, they can also present with orthophony, voice distortion, and pulsatile tinnitus. In patulous eustachian tube dysfunction hearing, this is one point. They can hear their own nasal breathing, and symptom gets relieved when the patient is in the supine position. This is one of the clinical clues by which you can suspect patulous eustachian tube, but this is not foolproof. However, although breath orthophony is uncommon in canal dehiscence, half of the patients with superior canal dehiscence syndrome may experience symptom relief and supine. Okay, this video is from Green Neurology, the same one of the patients with superior canal dehiscence. You can also the video with the 24 test.
In this patient, we test the somatosensory system by using our tuning fork. We put it on the sternum. Where do you hear the sound now?
Left ear.
Now we put it on the medial malleolus. Where do you hear the sound?
Left ear.
So this causes an unusual symptom.
This is another method, is what is called, you put just like the Henneberg sign, you put a pressure across the tragus, or do the Valsalva maneuver. Okay, you ask the patient to do the Valsalva. Again, it's a short, vertical throttling.
Ja, sehr schön. Nicht nach unten absacken, geradeaus schauen, eher zu mir her, ein bisschen.
Okay. So that's about that case. So only thing is that this we may not come across often when you come in such a patient community with that complaint. Keep this possibility in the back of the mind. So any questions?
Treatment may be surgery.
Some of them, in fact, many of them do not require any surgery. They get healed by themselves after a period of time. So some may require surgery.
They say a lot of exercises for this pateless eustachian tube.
I don't know.
Yeah, I'd send you that.
Okay. Exercise is there. Okay. Right.
Is it a conductive deafness or sensory neural hearing loss in this case?
Conductive deafness. That's exactly the pathophysiology I was talking about. Now, in these patients, you get bone conduction is much more than air conduction. Because air conduction, from the impulse coming through the oval window will be dissipated. Okay. On the other hand, in the case of when you do the conduction, when that reaching the tympanic membrane, scala tympani will be well appreciated, well heard. The one on the scala vestibular will be dissipated. So the difference between the two will be gross, and you get a loud sound in the case of when you do the bone conduction.
In that case, the tuning fork will also be lateralized to the.
Yes, of course, it will be lateralized to the affected side. Everything will be lateralized because your heart sound, everything will be lateralized to the affected ear.
Hearing tuning frequency.
No, I couldn't hear your voice is breaking. Can you repeat the question?
Tuning for frequency, is it the same vibrations or for hearing? Is it 128 or 256?
They can hear the sound. Can hear the sound itself. Sound.
Okay, sir.
Okay, it's a long case. This is a story of a 54-year-old female. Her complaint started as deformity of the right ring finger, which is progressively increasing for the last 1.5 years. For the last 1 year, she noticed numbness of the fingers of the right hand. According to her, first in the ring finger, followed by similar numbness in the middle finger, then the index finger, lastly in the little finger. The numbness was in the form that she was not able to appreciate the temperature sensation. She noticed similar deformity in the left and middle finger for the last 6 months, but to a lesser degree compared to the right hand. So complaints are deformity of the right ring finger, which is progressively increasing for the last 1.5 years. Last 1 year, she noticed numbness of the fingers of the right hand, first in the ring finger, subsequently affecting all the 4 fingers except the thumb. Numbness was in the form that she was not able to appreciate the temperature sensation. Similar deformity she noticed in the left hand. About 5 months back, she noticed difficulty in putting signature and the check got returned. However, she says that difficulty in putting signature has recently improved. No difficulty in doing finer activities of daily living with either hand. No neck pain, no root pain. No complaints pertaining to the legs. So this is the video of the patient. Okay, movements normal. All caleness were normal. Not spend much time on it. There was no horniness in it. Neck movements were normal. I couldn't make out definite wasting of the muscles, but there is a deformity. See that on the right hand, the middle and ring finger was flexed at the proximal vertex, not flexed at the distal vertex. There is hyperextension of the metacarpophalangeal joint. I could not passively completely filtrate that deformity. No vesical thenar, hypothenar present. Tone was normal. Our deltoid, biceps, triceps, all normal. Distance was normal.
Maximum other than cake.
It is also normal. Reflex is normal. Except is normal. Distance is normal. Distance is all. With the finger also. The intrusion appeared normal, testing link. The left side. It's also almost normal. It's not much of a difference.
Very good.
It's normal the left side. It's also normal. But so intrusion normal.
Very good.
ADM is also normal. Performance appeared positive bilaterally. See that number you say Palmer and Doshi were slightly weak on the third and fourth. That appeared slightly on the right side. That's okay. The left side is all normal. The only tone power normal. Come to the reflexes. Biceps, supinate and normally acceptable. I'll show the reflexes in 1 second later.
Please.
Supinate was normal. Well acceptable. But triceps is well acceptable on the left side. But right side is absent. It's just a thinker. There's no contraction in the right side. That is well acceptable on the left side. Finger pressure was absent on the right side. Well acceptable on the left side. Both rejects and quite brisk. Rejects and normal on the left side. And there was upgoing on the right side. That's upgoing. That side was in. Right side was. It was normal throughout.
2, 3, 4, 5.
Pain is appreciated equally all throughout. It's an equal throughout. But if the temperature is, the coldness is less on the middle. But more on the bottom. Increase on the middle. Index is not much.
ഇത് നല്ല തണുപ്പുണ്ട്, എന്നാലും ഇത് അത്രയും പ്രശ്നമില്ല. ഉണ്ട്
ഈ വെച്ചതും ഇതും തമ്മില
അത് ഏകദേശം ഒരേപോലെ.
പറയാമേ ഈ വെച്ചതും ഇതും ഇങ്ങനെ കുത്തി കുത്തി വരുമ്പോ എല്ലാം ഒരേപോലെയാണോ?
പ്രത്യേകിച്ചൊന്നും തോന്നില്ല.
ഇതൊക്കെ ഒരേപോലെയാണല്ലോ. ഇപ്പൊ എന്തെങ്കിലും
vibration normal.
വൈബ്രേഷൻ
ഇപ്പൊ ഉണ്ടല്ലോ.
ഉണ്ട്.
Joint stiffness normal.
മോളോട്ട്
ഇപ്പോഴേ
മോളോട്ട്
ഇപ്പോഴേ
താഴോട്ട്
that is lost. ഇപ്പോഴും
താഴോട്ട്
ഇപ്പോഴേ
മോളോട്ട് മോളോട്ട്
ലൂസ് ആക്കിയല്ലേ. ഇപ്പോഴോ
താഴോട്ട്
Again normal even the ring finger where is the
മനസ്സിലായില്ല.
ഇപ്പോഴോ
താഴോട്ട് താഴോട്ടാണ്
താഴോട്ട്
if but one mistake
ഇപ്പോഴേ
താഴോട്ട്
ഇപ്പോഴേ
on the little finger.
ഇപ്പോഴോ
മോളോട്ട്
ഇപ്പോഴേ
മോളോട്ട്
And she's currently on the fourth.
ഇപ്പോഴോ നല്ല ചൂട്. ഇപ്പൊ ചൂടുണ്ട്. ഇപ്പോഴേ ഇല്ല.
He's not able to separate the temperature of the fourth and the third.
ഇവിടെ
അറിയാം.
ഇത്
അറിയാം.
ഇത് ഇതറിയാം.
ഒരു ചൂടെന്ന് പറയാൻ പറ്റുന്നില്ല. മറ്റേതൊക്കെ നല്ലതായിട്ട് അറിയാം.
ശരി.
This is the key to the patient. There's no coordination technique. Okay.
First కొంచెం ఆగిస్తాం.
On examination, hairless normal corners, no obvious wasting of the muscles. Right ring and middle fingers are extended at the metacarpophalangeal joint and flush to the first interphalangeal joint, but not at the distal IP joint. Similar deformity was observed in the left middle finger as well. The deformity could not be passively corrected totally. Not normal in the upper and lower limb. Power in the upper limb, all normal except for the mild weakness of the palmar and brachio of the right ring and little finger, and adductor pulse of both hands. Lower limb all normal. TTR all normal except that diminished right tricep jerk and absent finger flexion right on the right side. Left finger flexion was well elicited. Senses is the only abnormality, decreased temperature sensation over the right ring and lesser extension in the middle finger. The rest of the sensations were normal. She made some occasional joint sense mistake in the right little finger. Gait is normal. So, what is your diagnosis of this patient? Localization problem diagnosis.
Intramedullary cervical cord lesion at C7, 8, T1.
Very good. Okay, that is okay. Any other possibility you want to keep anyone?
Yes, sir. Same localization with involvement of the anterior horn cell as well as the spinothalamic tracts and pyramidal signs. Mainly in intrinsic cord lesion.
Yeah.
Possibly something like a cavity.
Is it spinothalamic tract or crossing pain fibers?
It can be crossing fibers also, sir. I mean, crossing fibers.
It's only that segment is affected, no? It's unlikely for spinothalamic tract.
Yes, sir.
Okay. So, intramedullary lesion. Any other possibility? Okay. In fact, that's what initially I thought also. So, go to the investigation. This investigation, she came with this investigation. This is the MRI cervical cord. This is a surgical cut. This axial go one by one. This is CVJ from 1. Go slowly. This is C2, C3. There is no cord cycle inside. C4, C3, C4. C4, C5. C5, C6. C6, C7. And one cut for C7, D8, D1. This is the coronal cut. So, what do you want?
Nerve conduction study.
See, CV junction. What about the foramen magnum level, sir?
That's normal. Normal. I'll show that picture one second. It's a foramen magnum region normal.
Was there any nerve thickening?
Pardon?
Was there any nerve thickening?
No nerve thickening. No nerve thickening.
Sir, definitely patient has a pyramidal sign that cannot be accounted by any nerve root plexus lesion. So there has to be some cord lesion
What about
Correct.
contrast, sir? Contrast?
Contrast was not done because there's nothing could be seen in these things, so contrast may not be useful in this patient.
What about MRI brain?
MRI brain I did not take because I never suspected MRI brain lesion here.
Because there's nothing here.
Bilateral, sir.
Yeah, triceps is decreased here on the right side. Finger pressure is absent on the right side.
It could be a C8 T1 root or the lower.
Could be root plus compression of the cord. That's good possibility. But it is bilateral. When deformity is bilateral, the sensitive finding, as you see correctly, is only on one side.
It could be MedSam. It's bilateral.
No, MedSam you cannot die because right plantar is upgoing. He has got what do you call? It's not fitting with the. Do you think it's fitting with the nerve lesion?
The upgoing plantar may be because of some other reason. Because you don't find anything on the scan, no? So
there's nothing on the scan.
So dorsal cutaneous nerve of ulnar. Dorsal cutaneous nerve of ulnar.
But again, you can't explain many things. The triceps reflex is absent on the right, not on the left side.
So the middle finger is also absent. So that cannot be accounted by ulnar nerve lesion.
Yeah, correct.
Could be a multifocal neuropathy.
Anyway, you want conduction? No, I'll give you the conduction.
Repeat the MRI brain spines.
Conduction will be normal.
Conduction is normal. Is the conduction.
Repeat the MRI with the.
When was the MRI done? When was the MRI done? How long into the?
It was done about say 1, 2, 3 weeks prior to me seeing the patient.
How long is she symptomatic?
This is symptomatic for 1.5 years. 1 year.
There's no point in repeating, no? Maybe you do a 3 Tesla MRI.
Okay, right.
MR with contrast, sir.
Okay, right. So what do you want me to do? So what I examine? Since everything was started examining the patient 1 second, that you have to always do. So sometimes a patient may be say confusing the picture clearly. So you have to reconfirm what we got is correct or wrong. So if we're able to get the reflexes again, then it's a re-examination. The findings are the same. Triceps is well normally. Supinated normal. Triceps on the right side, left side is well insitable. Right side is absent. Just all a picture.
Left is absent.
Sorry, right is absent. You are taking the from above. That's the left side. It's a pressure on the right side. Camera is taken from behind the head. See the left side is very extra bilaterally. Consistently upgoing. So
Ankle sir.
But he has got temperature. I'll come to the examination. The examination. She was complaining of numbness. Examination also found some problem. So what will you like to do? So I did an EMG to find out whether there's a real lemon parallels or not. So I did an EMG which was convincing. No typical deprivation I could make out. Many other muscles, everything was normal, no convincing denervation. So what do you want now?
Is this deformity? Did this deformity happen after the onset of weakness, or?
Yes. No. The weakness she never complained. She came with the deformity. Then she noticed the numbness.
So repeat MRI 3 Tesla.
Correct. So I did same thing. I asked the patient to come over to me. This patient I saw in Kollam. So as the patient come to random side, get a thin cut section of the cervical spine again. So I insist she came. So I did the cervical spine. This is done in PRS hospital. Where you find that, you see, this is the cut here. There is a osteophytic compression right side of the cord here. Okay. At this level. Here again, lower cut also, there is another anterior compression. It's only compressing the cord, no signal change within the cord. There is no intermediate lesion, which I suspected just not there. Here also there is osteophyte anteriorly. I'll show the sagittal cut once again. You can make it dot a little more clearly there. This is C7D1. Thin sagittal cut I took. See, this is the level C5, C6. I'll bring that. This is exactly the level where you can find this kind of a compression here. Bring it down. And later you can find the osteophytic compression at the C5, C6, and C6, C7. Compressing the right side of the cord. This was not seen in the previous MRI. It is the compression of the right half, right side of the cord. Let's say when the canal is compromised, you can see the canal is compromised. Here also the canal, the foramen is compromised. See this one. This again I will show them. Bringing the cursor down. That's a level. That's a level in which you can see the. This level is the one you can see the osteophyte. That's the level. You can get the compression of the cord here on the right side. Compression the root also on that side is compromised. Okay, this is the level. Now the question is, what do you want to do now? We found osteophytic compression, 2 levels on the right side, compressing the cord.
She has a long neck, and probably there is a dynamic compression. So give a cervical pulse.
Okay, but is it not curious that how to explain this? Okay, so what will you do now? Surgery?
Conservative treatment, sir.
Still, it could be multiple cutaneous nerves, distal nerves, or deep ulnar nerve.
Okay. I'll tell you
Something
reason.
like leprosy enhancements.
Okay, so what it is, in fact, I did not think of it. Just like you all thought, I also thought most likely intermittent lesion. But seeing the repeat MRI also, I was least convinced that there is something else. Because I cannot explain why this wasting has occurred in this patient. There is nothing in the cord. I cannot explain.
Why this what, sir? Why this?
Why this
explain what?
deformity of the fingers here. It is something like only not confined only to 2 fingers. So I started thinking and going back again.
Were the flexor detour and profundus weak?
Normal. No, let's see.
Why is it not clawing then?
I'll come to that. Just
pure neurotic form of leprosy. Pure neurotic.
Okay, I'll come to that. Now, first of all, we have to find out whether the lesion is in the nerve or not. No, correct? Or in the anterior cell or not, or the muscle or not. Let us find out that first possibility. Let us come to back to the original question. Was it a claw hand deformity in this patient? That's the first thing. Okay, let us come back.
Not really claw hand because the distal.
Correct, exactly. So initially, because of the sensory, we are all carried away because got some pyramidal signs. But there is something which is odd. The fingers are extended at the MB joint and flexed at the proximal interphalangeal joint, as we all expected in claw hand, but not at the distal MB joint. Why should it occur in claw hand? That should not occur. How can you explain that? This is not possible with either lumbricae or introsci weakness. because since they are inserted in the extensor expansion, the beacon should produce flexion at both proximal and distal IP joints. So I started digging up and find out why should it occur? Is there any way by which these muscular involvement can partially produce this kind of an affection? So this is the deformity.
Could be flexor return profundus is also weak.
No, flexor is overacting. Flexor profundus is overacting. Then see, this is the position. The proximal, this approach of the metacarpophalangeal joint, flexion of the proximal phalange, but not in the distal.
The flexor return profundus was working and the middle phalanx should be flexing, no?
Pardon? If it is...
If the flexor return profundus was working normally,
yeah,
the distal phalanx also should be flexed, no?
Correct, exactly.
So it was not working.
But here is kept extended.
Correct. So let us see. So this so started here. The finger is flexed at the proximal IP joint, extend the IP. That cannot occur with that. So how can this occur? This can occur only if the middle slip on the extensor expansion get torn. So I started examining and then looking for studying the extensor expansion first. So let us look at the anatomy of the extensor expansion. This is extensor expansion. This extensor tendon, on the dorsum of the first phalanx divides into middle slip, which goes to the middle phalanx here. There are two lateral slips which go anteriorly through the side of the middle phalanx and get inserted in the base of the proximal phalanx. That is how the extensor tendon work. These lumbricals and intrusiae get attached to the extensor expansion, and the contraction of which produce both extension of the middle phalanx as well as the distal phalanx. Okay, this muscle involvement cannot produce selective involvement of affection of one phalanx. That is not possible. So let us see. So this is extensor expansion. Again, showing you once again. Extensor tendon, this expansion. This is a middle slip which is get attached to the middle phalanx, and the lateral slip goes forward and gets attached to the distal phalanx. Okay. This is again the exit. And the intrusion lumbricate attaches an expansion here. So if it's a lesion here, it should affect both. So if the finger should get flexed at the proximal IP joint, just like a patient, and extended at the distal IP joint, what should have happened? The middle slip should not act. At the same time, distal slip should be active. Correct? Then only this will happen. This cannot occur with intrusive lumbrical weakness. So this is called, now let the other way around. Suppose if the distal slips are torn like this, you get this deformity called the mallet finger or baseball deformity. This is not our patient. This is if the distal slip alone is cut, gone, you get flexion of the distal phalanx. This deformity is called the baseball deformity or mallet finger. Okay. This is the mallet finger. Now, I forget about this mallet finger, or I will not spend on that. Now, what will happen if the middle slip is get torn? This is what is going to happen. Just like our patient. Here, as in our patient, the middle phalanx get flexed at the proximal PIP joint and extend the distal phalangeal joint. This deformity is called the Bottomley deformity. So this is what is going to happen here. This is central slip. When that is torn, this alone will be acting. The lateral slip will be acting. So this will go flexed. When it is flexed, this lateral slip will further flex the proximal phalanx, because the line of pull become different. It becomes easy for the thing to become flexed again. Okay, this will be more flexed. This will be extended. So this is the Bottomley deformity, the breakage of the middle slip. And because the pull is there, this will further extend the distal phalanx. When the finger is flexed, yeah, please.
This affect multiple fingers?
Multiple fingers, yes, multiple fingers. I'll come to that.
So all these are torn.
I'll come to that just a minute. So this is just first of all explain why it cannot be flow hand deformity, why it is not muscle. That's the first decision. Next, we will come to the etiology part. So this usually due to the result of trauma in the acute setting caused by the rupture of the PAP joint. So what is this botanier deformity? Results from the triangular ligament and the central slip lesions of tendon digit disrupted. This disruption of the ligament and tendon will cause lateral bands to displace more ventrally. This results in forced flexion of the finger at the middle post proximal phalanx and subsequent passive extension of the distal IP joint. Over time, the oblique retinacular ligament gradually contracts. This ligament contraction will gradually worsen the hyperextension of the deformity of the joint. So usually this is the result from the laceration of the central slip and dorsal capsule or a sequelae of inflammatory arthritis like rheumatoid arthritis. So what will you do now? So now we know that even though he has got some compression of the cord, that is the root of... Pardon?
Was this patient having rheumatoid arthritis?
Yes, exactly. Let's find out. Let's find out. So what will
why
you do?
it's because the middle slip, why is there a weakness of the palmar abductors and the adductor polystis?
Right. That in fact actually is not a real weakness. Because of the joint deformity, she is not able to extend the full power. And if you, the weakness also very mild. Only the all other muscles are spared except the fourth and fifth. That the fingers with the affected joint is causing the mild weakness. Probably she is not able to exert full power because of the associated pain. There is a.
Did she have pain?
On pressure, there is a pain. She never complained of pain. Let's find out. So, in fact, this patient, before they came to me, she came to me. This was seen by rheumatologist already. This is the X-ray done by the rheumatologist. He did not find any grossity abnormality there. And he worked up the case also. He did a rheumatoid factor, negative, ANA profile negative, anti-CCP was negative. So since there is no obvious rheumatoid factor positivity, he initially thought botanic deformity. And moreover, the patient complained of sensory loss and the numbness. Then that is why he is referred to us. So since he did not find an obvious rheumatological problem, she was referred to us. And what will you do? So I said, repeat the X-ray. So I repeated the X-ray in our hospital. And you find the changes characteristically of, see the joint there? It is eroded. That particular joint is eroded. The left little finger is also, there is changes here. Then that will be more evident. You enlarge it, you can find the deformity of the joint and also in the thumb. That is why she's getting so-called, what do you call the pseudo formants and something like this is obtained because of the pain in the distal phalanx. She is not able to flex it properly. This is the other joint affected. That's the right side. The left side also, you see the little finger is affected here. The thumb is also affected.
That can explain the motor weakness, but how do you explain the sensory signs?
Correct, you can't explain. I'll come to that. So there's a cord involvement that will come. So this is again lateral view, so various abnormality of the joints. So obviously she has got an inflammatory arthritis causing the deformity of the fingers. The finger deformity is not claw hand deformity, it's a botanier deformity. And so then I started discussing with the radiologist, then how could you explain this thing? Other possibility strongly to be considered is psoriatic arthropathy, which can affect these distal phalanges. So that is finally the most likely psoriatic arthropathy. So this lady has got a cervical disc at C6, C5, C6, and C6, C7, causing radiculopathy, causing absent rises, present finger flexion, and myelopathy or the pyramidal signs on the right side, probably bilateral more on the right side. And why this pain temperature alone is lost, I cannot explain why this patient is affected, but this is the finding.
The 1 point. So psoriatic arthropathy affects the distal interphalangeal joint.
Yes. Well, that need not necessarily distal, can affect the proximal also.
Then another point is that why can't it be neuropathic joint?
Look, neuropathy joint patient has no other problem. Like you can, but the left side is also affected without any pain loss. Left hand is also affected.
Great case, sir.
And you see, the deformity is actually not explained by an arthropathy. It's explained only by the what do you call, the rupture of that middle sling. So the thing is that when we usually get carried away by the neurological findings, it always think that when the deformity causes something that is really fitting with them. I also went in the wrong direction initially. I thought it's intramedullary. But when it is not, when the investigation proved the other way around, I was thinking, what other way you can explain?
Seronegative.
One doubt.
Yeah.
Seronegative rheumatoid arthritis.
Yeah, maybe seronegative rheumatoid arthritis is a possibility. Whatever it is, inflammatory arthritis, that is causing the deformity. She came with the deformity. She's not bothered much about the numbness or anything.
One doubt, sir.
Yeah.
Sir, if the intramedullary lesion producing this much of deformity, so won't it affect the anterior horn cells and won't it the patient become more affected in her hand motor activities? Can it be like this? Like pure sensory is now predominant.
Yeah, the intramedullary, it all depends upon how severely the anterior horn cells are affected. Here the affection is very mild. Why should it produce any disability for the patient? A disability is only.
If the crossing fibers of the spinothalamic tract is so much affected to produce a deformity,
No, remember, the deformity is not because of the pain loss. Deformity is only because of the joint problem or the muscle waste. Deformity is second due to the muscle involvement. Here it is not due to the muscle paralysis, which cannot explain the deformity. The deformity can be explained only by the tendon involvement or the joint problem. That is the first thing to know. So here the intramedullary lesion producing, if it is there, the pain loss can be, temperature loss can be explained. That is not going to cause any deformity or disability to the patient.
Okay, sir.
So during our MD days, you used to tell that you repeat the scan after 1 year and then you will find the.
Yeah, right. So what a neurologist should be something like a Sherlock Holmes attitude should be there. You have to
Why can't we do a synovial biopsy?
No, see, now the ball is in our tower court. I'm going to refer to the rheumatologist to manage whatever it is. See, yes, referred to us to find out why this is a neurological problem. So I tell you, this is not a neurological problem. This is an orthopedic problem. And we are demonstrated by X-ray itself. Now we'll take over and do start methotrexate, whatever it is, let him start. Okay. Shall we go to another case also?
Yes, sir.
Yes, sir.
We are not record from the shock. Yeah. Okay, I always tell that a neurologist should be a good ophthalmologist, could be ENT people as well as good orthopedist also. Then only we can truly become a neurologist. We should know something about all these things. Okay, this is a story of a 60-year-old. It's a good case. Not a long case, short, good case. His complaint started as acute onset of left-sided weakness, associated facial elevation to the left, numbness of the left face, and has noticed he was squint. Sometime, I didn't forget, 3 or 5 months back. The weakness improved to a great extent after 2 weeks. And on recovery, he found that he has defective vision, and his left hand will go astray, and it would move away from the table without his awareness, and may even push the plates on the dining table. His hand will go by its own and remove the plate on the table. So if it started as something like an acute stroke with left-sided weakness, facial elevation to the left and numbness to the left of the face, then it was noticed as squint, maybe brain stimulation. Weakness improved to great extent after 2 weeks, and on recovery, he found that his was defective vision, and his left hand would go astray. It would move away from without his awareness, and may even push the plates on the dining table. This is one examination. It's got interesting ocular findings. You just concentrate on. This is a primary position. He has got this kind of a vertical up and down movement. Some rotary component. These are looking to the left side. And looking to the right side.
Okay.
Looking up. Okay. Looking down is also okay.
ഇങ്ങോട്ട് ശരി ഈ പോയിന്റ് തന്നെ നോക്കണം കേട്ടോ.
Ocular comparing was not corrected.
ഡോക്ടർ വെല്ലി തന്നെ നോക്കാം. ശരി മതി. ആ സാർ ഈ കണ്ണ് മുറുക്കി അടച്ചേ, മുറുക്കി അടയ്ക്കാ, മുറുക്കി അടച്ചു. ഇനി പല്ലൊന്നിനെ കാണിച്ച ഈ മതി. ചുവാ തുറന്നേ, ഹാന്ന് പറഞ്ഞ് എന്നോട് പറഞ്ഞ് നാക്ക് നീട്ടിക്കേ മതി. അങ്ങനെ ആ ചിരിവ അടിച്ചോ. ഇനി വാ ചുമ്മാ തുറന്നാൽ മതി, നാക്ക് നീട്ടണ്ട.
Coming to the motor system, here fast to the left upper limb. Get pseudo-thetod-like movements of the left hand. The hand will go astray when he closes the eyes. The more form. It goes down.
വലത് യൂണിറ്റ് ഒരു വെള്ളം ഇങ്ങനെ തൊട്ട് മൂക്കത്തോട്ടെ, ചില മൂക്കത്തോടെ അതിൽ തൊട്ടെ. ഈ കൈ കൊണ്ട് ചെയ്യും. ഇത് ഈ വലത് യൂണിറ്റ് എടുത്ത് കൈ തന്നെ.
That's to take the object the right hand now. Yes, let's see how he's doing it. Because in some dystonic positioning, he's not able to manipulate to take the object fully back.
ഇനി ഇതില് ഈ ഒരു പോയിന്റ് കൈ കൊണ്ട് ഇങ്ങനെ തൊടണം. ഈ കൈ കൊണ്ട് തൊട്ടെ, മോള് ഇവിടെ തൊടണം. അതല്ല മറ്റേ കൈ കൊണ്ട് തൊട്ടെ. അല്ല കണ്ണിന്റെ എല്ലാം ചെയ്തോ. ഇനി ഒന്ന് മുറുക്കി ഒന്ന് പിടിച്ചാൽ നോക്കാം. ഇത് ഒന്ന് മുറുക്കി, എൻ്റെ കൈ മുറുക്ക്. വിട്ടേ വിട്ടേ വിട്ടേ, മുറുക്കി പിടിക്കേ മതി. വിട്ടോ, കൈയിന് പൊക്കി പിടിക്കണേ. എടുത്ത് വെച്ച് ഈ കൈ ഇങ്ങനെ ഇരിക്കട്ടെ കേട്ടോ. ഞാൻ കണ്ണടച്ച്
Closing the eyes, the left hand comes down. The fingers come down. The only front side is passing in the left only. Forwards are open.
പൊക്കി പിടി, വിട്ടോ. ഇത് പൊക്കിക്കേ. താത്തി താത്തി ആകെ മുന്നോട്ട് അതിന് പിടിച്ചോ. സമ്മതിക്കല്ലേ, ഇതിനെ പിടിച്ചോ. ആക്കെ സമ്മതിക്കല്ലേ.
Reflex are all equal. There's slightly minutes of that state. Let's Cancer on the right side, need to get on the left side. Sensation, but this is many of the 10 sensation on the left side. But this is very not particularly because even in parietal, sometimes he may not say yes every time. Sometimes he misses. It's happened on the left side also. No, he did not say. No, he did not say. But consistently every time on the right side. No sensory inattention.
ഈ കുത്തുന്നതും ഇതുവരെ പോലെ ഇതുപോലെയല്ല. ഇവിടെ നല്ല ക്ലിയർ ആയിട്ട് അറിയാം. ഇവിടെ എന്തോ പോലെ വ്യത്യാസം. ഇവിടെ കുത്തുന്നത് ഇത് വ്യത്യാസമുണ്ട്. എപ്പോഴോ
ഇവിടെ അറിയാം, പക്ഷെ അത് ലൈറ്റ് ആയിട്ട് നിന്നു.
ഇപ്പൊ ഉണ്ടോ?
ഇപ്പൊ ഇല്ല.
ഇപ്പൊ ഉണ്ടോ?
ഇപ്പൊ ഉണ്ട്. ഇപ്പൊ താഴോട്ട്.
ഇപ്പോഴേ ഇപ്പോഴേ അതേമാതിരി
ഇപ്പം താഴോട്ട്.
അറിഞ്ഞോണെന്ന് പറഞ്ഞാലും മതി. ഇപ്പോഴോ?
ഇപ്പൊ അത് എങ്ങോട്ടാണെന്ന് അറിയില്ല. ഇപ്പോഴും താഴോട്ടാണെന്ന് തോന്നുന്നു.
ശരി. ഇപ്പൊ എങ്ങനെയാ?
താഴോട്ട്.
ഇപ്പോഴോ?
മുകളിലോട്ട്.
ഇപ്പോഴോ?
താഴോട്ട്.
ഇപ്പോഴേ? എത്ര ചെയ്ത് കണ്ണടച്ചാണ് പറയണേ. ഇതെത്ര? ശരി. കണ്ണടച്ചോ? ഇല്ല, കണ്ണടച്ചോ? ഇതെന്നതാ?
He could say that object with the right hand. So gate. See the position of the hand on the left side. But it's turning positioning of the left hand. So let us see, coming back to the findings. What do you think about the ocular findings first?
For the right abduction weakness, then probably a slow vertical nystagmus or a slow ocular dipping.
Ocular bobbing, sir.
Ocular bobbing.
Or a slow pendular nystagmus. Vertical.
It is not a jerk nystagmus. There is no fast or slow component. It's not ocular bobbing or dipping because in ocular bobbing there is a fast downward component and a slow upward component. The other opposite will be dipping. So here it is not. If we look, the velocity is equal and looking. Now let's see the velocity now. Equal up and down. Okay, some rotary component also there, but it's equal. There is no fast component. It's as if going up and down in a dipping fashion. What is the nystagmus called as?
Seesaw nystagmus.
Okay, this is not seesaw. It's not going up and down. It's rhythmically going up and down. This is the pendular nystagmus.
Pendular.
Very good. The vertical pendular nystagmus got acquired pendular nystagmus. And where do you find acquired pendular nystagmus?
Central tegmental tract.
Yeah, very good. One is central tegmental tract involvement. The other is in brainstem lesion. Multiple sclerosis can produce. Pendular nystagmus is also described with the Whipple's disease. So classically, it is, as Joy was telling, it is due to the central tegmental tract involvement. So that's why I look for the palatal nystagmus. But there is no palatal nystagmus in this patient. You saw the palate. That is perfectly normal. The case of the palate. There is no palatal. You can look at the palate for some time. The eyeballs are moving up and down, but there is no rhythmic movement for the palate. That does not exclude a central tegmental nystagmus. Okay, now let's come to the eyeball method. For that, I will show these frames. This is on looking to the left side. Left abduction is full, right adduction is partially restricted. Agreed?
Yes, sir.
Yeah, it could mean that either right middle rectus is weak or a right partial IN. Correct?
Yes.
Partial middle rectus or partial IN. Now this is on looking towards the right side. Total abduction failure on the right eye, partial abduction failure on the left eye. So where is the site of lesion? You can't explain by gaze palsy because there's no asymmetric. So he has to have right lateral ectasis weakness. The left adduction failure can be due to anything. Can be due to part of the associated right gaze palsy, or part of the left INO, or even part of the left middle. Anything is possible. So what is logically the thing which is can explain everything, but try to think of a single, always in neurology, try to think of a single lesion which can explain everything.
The right PPR of right MLF.
Okay, very good. So it could be not PPRF alone. A PPRF alone should not produce such an asymmetrical.
Also.
So like this.
Both.
Pardon?
Sixth nerve nucleus and internucleus. Both, I mean, PPRF as well as the gaze center.
Correct. It should be right sixth nerve nucleus, abduction nucleus, plus right gaze center is affected.
And also right MLF.
Right, left MLF.
Yeah.
Then you're right. Right MLF is also right. What you said is correct. So right abduction nucleus, right gaze center as to using right MLF. Not because of this thing, because of the previous one. Okay, these are looking to the right side. But this one, right MLF, right middle rectus. So for middle rectus, you have to take the lesion to the midbrain. So don't think of a middle rectus, more likely right MLF. So everything can be explained by a right-sided pontine lesion, which produces abduction nucleus, right gaze center, or and right MLF. Otherwise, you have to implicate bilateral MLF. So for that, you have to bring the lesion to the left side. That's also possible. But more logically, this adduction failure here would have been due to the associated gaze palsy on the right side. Okay. It is not pure gaze palsy because there is asymmetrical. This is grossly restricted. This is partly restricted. So it has to be an element analysis. Okay. So this is this is right lateral rectus palsy with right gaze palsy plus left INO. Then acquired rotary pendulum nystagmus, vertical rotary nystagmus, impaired vibration, JPS, and impaired touch, and defective vestige hypnosis in the left side.
Is it left INO or right INO? Because right adduction is impaired, no?
Right, sorry, right INO, not left INO. Left INO means it's
left middle rectus is involved.
Right. In fact, you can call it as a left INO rather than right one, because I'll tell you, if you explain by this thing, the failure of or looking to the right side, here, this failure of adduction is part of the right gaze palsy. The failure of adduction on the left side is the right INO. Correct? Here it has to be right INO.
Yes, sir.
So this is right INO, not left. Type A the tip. So let us see this, and it's also got left hand dystonia, and the dystonia is due to what?
Sensory.
Yeah, correct.
Middle limb meniscus.
Yeah, perfectly right. It is due to the loss of proprioceptive input causing abnormal hand posturing. As told one of the 2-3 weeks back, in one class we showed severe abnormal posturing due to proprioceptive. But one of the again Joy's case, where the patient cannot manipulate or reach the target because of the sensory deafferentation. So proprioceptive input can cause many kind of physical disability, one of which is abnormal posturing, and cannot direct the hand to the intended target. Because for the motion feedback, you require proprioceptive input.
Is this sensory impairment much more than for a brainstem lesion? So it could be a thalamic lesion also?
It could be. It could be that, where it may be anywhere, but think of a single site, we can think more likely to be sensory tract in the brainstem is affected. Ultimately, it's going to the thalamus only.
Dystonia or arthritosis, pseudoarthritosis?
No, it's recently we were in the last study scan meeting, we were telling that the arthritosis term is not taken away. It's all part of dystonia only. But for conventionally, we use pseudoarthritosis and all. It actually is a dystonic worsening. Typically dystonic. But this kind of writhing movement, sometimes you call arthritosis. No harm in calling arthritosis. So this is the investigation done earlier at the time, 5 months back, when he had the acute stroke. So this is the CT scan. Taken at that time. This is MRI. It's affecting the right side of the pons, partly going to the left side of the pons as well. And lower midbrain.
It's a bleed.
You have to tell me what it is. Okay, this is also the picture.
It looks like a cavernoma, sir.
Sir, angioma, cavernous angioma.
Right. This looks like a cavernous. It's a bleed. But he said it's all correct. This is a bleed, but bleed in a cavernoma. Why do you want to say it's a cavernoma? Because look at this, something like a popcorn appearance, also a little more picture. So in fact, I repeated the MRI here now presently. This is the present MRI. But how to explain that? I'll come to that. Now look at the MRI now and tell me. This is a diffusion. Okay, before that, I'll ask you one question. Why did I wanted to repeat MRI, not necessarily spending the time on the spending the money on the part of the patient?
Inferior urinary nucleus hypertrophy.
Very good. That's the idea of doing it, because that will not be seen in. So this is the diffusion ADC. This is the flare. It's the pons. Over here they can be seen. It's a membrane. You can see hyperdensity. Make a hyperdensity here, the urinary nucleus on the right side. That's urinary nucleus. That one. Also one more. That is a blooming old solid. This is W again. And 2-3 interesting findings also in this patient and subsequent to the. That's hypertrophy of the urinary nucleus is there. Density there. Get some abnormality here, also I'll stop short here. Wait. Did you see the red nucleus on both sides? The right side is atrophied compared to the left side.
Yes, sir.
Yes,
Yeah, I'll tell you that, but I'll show. There is another hemorrhage seen in the left quarter. Maybe again, it may be covered, maybe covered. In this picture, you can make out typical appearance of the popcorn appearance of a governance image. This is again, this is the typical Oliveri hypertrophy. It's unilateral. Definitely it's affecting one side, which is the cover. That is the even is not contributing much. This is a static picture. You can see the cavernous hemangioma here. See, this is the supracerebellar peduncle. Okay. Then this is atrophy of the red nucleus there. Okay, that's the story. In fact, I did not pick up this atrophy, only picked up with the radiologist. He told this can occur with the Oliveri nucleus goes into atrophy, the inferior Oliveri nucleus goes into hypertrophy. Sorry, red nucleus goes into atrophy, Oliveri nucleus goes into hypertrophy.
And explanation of the cervical, what is the explanation?
Because the tract is because of the Guillain-Barré triangle affected, no? The fibers are going from the dentate nucleus through the supracerebellar peduncle to the red nucleus. So when that is affected, when that input is affected, you get atrophy of the red nucleus. When the red nucleus output is gone through the central tegmental tract, inferior nucleus becomes hypertrophic. This is one peculiar condition where the tract lesion, usually when the tract is affected, the target organ atrophies. Here the target organ hypertrophies. Because the main input to the inferior nucleus is inhibitory in the central tegmental. But after some time, the Oliveri nucleus hypertrophy becomes atrophy. This I have shown some time back. See, over 6 months, it becomes atrophied. Another 1 to 2 years, Oliveri nucleus go into atrophy. It becomes only a thin band of hyperintensity.
Why, sir?
Pardon?
Why it goes into atrophy?
Yeah, it goes in that because initially the hypertrophy is because the inhibition is lost, the neurons get hypertrophied. After some time, that again goes into the natural evolution because there's no further activity with that neurons, it goes into atrophy. That is evolution of of the lesions of the central tegmental tract producing parenchymal or acute medullary.
So there's something called slow ocular bobbing, no?
Slow ocular bobbing. No, whatever be it, it should have a fast component and a slow component. Here there is no fast component, only pendular movement. Okay. Any questions? We can close already for it's become 9:50 now. Okay, shall we close?
Thank you, sir.
Okay. Good night, sir.
Thank you.
Thank you.
Good night, sir.
Thank you, sir. Thank you.
Good night.
Good night, sir. Good night.
Good night.